Welcome to Roadmap to Residency. Hello everyone, I am Abhiraz. Welcome to our Club to 50 matchmaking sessions. We'll be running through some questions with you guys to help you on a journey to a 250. We are currently in our nephrology modules, and this video is all about complications of chronic kidney diseases. So which of the following areas most likely represents this patient's current metabolic state? A 64-year-old man comes to the office with fatigue. He has hypertension and poorly controlled diabetes, complicated by nephropathy and peripheral neuropathy. His renal function has declined steadily over the last few years. On examination, his conjunctiva are pale and he has bilateral 1 plus peripheral edema. Sodium 133, potassium 4.4, chloride is 98, bicarbonate is 22, blood urea nitrogen is 76, and creatinine is 5.8. On the graph below, area C shows the normal relationship between the serum concentration of free calcium and PTH hormone. Which of the following areas most likely represents this patient's current metabolic state? A, B, C, D, or E? So this question is asking us mainly about the PTH and the calcium state in case of chronic kidney disease patient. So let's see something here. So in case of CKD, where there is decreased GFR, there is decreased vitamin D. Okay, whenever there is decreased vitamin D, there is decreased intestinal calcium absorption. Also, due to the decreased GFR, there is the phosphate retention and there is high serum phosphorus. Now, all this lead to the low serum calcium. And whenever there is low serum calcium, it causes increase in the PTH synthesis. So decreased calcium, decreased vitamin D, and increased PTH in case of CKD due to the secondary hyperparathyroidism. So in the physiological state, PTS causes an overall increase in the serum calcium and a decreased serum phosphate. So by the following effects, there is increased osteoclastic bone resorption, releasing calcium and phosphate into the serum. There is increased renal calcium reabsorption and reducing phosphate reabsorption, increasing formation of 125 hydroxy dihydroxycholecalciferol, which increases the intestinal calcium and phosphate absorption. PTS production is very sensitive to small changes in the serum free calcium and is regulated by a negative feedback mechanism. So wherever there is increased calcium, it will suppress the PTS, but decreased calcium will increase the PTS secretion, like in our patient. In CKD, the phosphate clearance declines due to the fall in the GFR. The increased phosphate binds the free calcium, resulting in hypocalcemia, and there is loss of normal renal parenchyma, which decreases the vitamin D synthesis, resulting in a significant decline in the intestinal calcium absorption and calcium release from the bone. Now, this further exacerbates the hypercalcemia, which along the hyperphosphatemia and low calcitriol stimulates the PTS production, and it is called as secondary hyperparathyroidism. So, which of the following is the most likely cause of the anemia in this patient with chronic kidney disease? Okay, so in this case, there is increased calcium, but there is increased PTS, but there is low serum calcium. So the answer is A. So, which of the following is the most likely cause of anemia in this patient with chronic kidney disease? A 55-year-old woman with a history of poorly controlled hypertension and type 2 diabetes mellitus is undergoing regular follow-ups for CKD. Her renal function has progressively declined and she is currently classified as a stage 3 CKD. Now, despite the optimal blood pressure management, she presents with increasing fatigue, weakness, and difficulty concentrating. The patient denies any gastrointestinal symptoms, melena, or recent illnesses. And on examination, there is evidence of mild peripheral edema. Lab tests reveal a hemoglobin of 9.5 with a MCV within normal range. Iron studies demonstrate normal serum iron and total iron binding capacity, but ferritin levels are at the lower end of the difference range. So which of the following is the most likely cause of anemia in this patient? Iron deficiency, vitamin B12 deficiency, folate deficiency, erythropoietin deficiency, or hemolysis? So the most likely cause of anemia in this patient with chronic kidney disease is erythropoietin deficiency. So CKD often leads to the decreased production of erythropoietin because kidney is damaged, kidney's function is damaged, kidney's structure and anatomy is damaged in chronic kidney disease patients. So whenever there is damage to the kidneys cannot produce erythropoietin, and that decreased erythropoietin will lead to the decreased red blood cell production and consequently anemia in this patient. And one thing to note always is that in CKD patient, due to the erythropoietin deficiency, which is also lead to the chronic disease-induced anemia, the anemia is of normocytic normochromic type. So how do we approach a case of anemia in CKD patients? So we measure the MCV. If the MCV is normal, we go for the reticulocyte count. If the reticulocyte count is normal or low, we label it as anemia due to the chronic kidney disease, and we evaluate for iron deficiency. If there is iron deficiency is present, we go for iron supplementation. What if there is no iron deficiency, like in our patient, we go for if checking the hemoglobin. If the hemoglobin is less than 10, we administer the synthetic or external erythropoietin hormone. Okay, like in our patient, it was less than it was 9.5, so we have to administer erythropoietin in that patient. So in some cases, anemia may be due to both CKD and iron deficiency, resulting in microcytic anemia. And in this setting, anemia will persist with normalization of MCV after iron depletion, demonstrating the underlying contribution of CKD. So whenever there is concurrent iron deficiency anemia, along with the anemia of CKD, you first replenish the iron store, because you would not know that the anemia is due to CKD, because the picture is microcytic hyperchromic. And whenever you ultimately treat the iron deficiency cause, then the blood picture changes to be normocytic normochromic, and then you know that the patient is having anemia due to the CKD also, and then you treat the CKD related anemia with erythropoietin supplementation. So, which of the following is the most likely contributing to the symptoms in this patient with chronic kidney disease? So, a 60-year-old man with a history of hypertension and chronic kidney disease presents to the nephrology clinic for a routine follow-up. His renal function has gradually declined, and he's currently classified as a stage 4 CKD. Now, recently he has experienced episode of nausea, vomiting, and generalized malaise, and lab tests reveal a serum bicarbonate level of 20. Now, which of the following is the most likely contributing to the symptoms in this patient? Respiratory acid alkalosis, respiratory acidosis, metabolic alkalosis, metabolic acidosis, or mixed acid-base disorder. So the symptoms of nausea, vomiting, and generalized malaise, along with the lab findings of a low serum bicarbonate level, are indicative of metabolic acidosis. In chronic kidney disease, the impaired renal function leads to a decreased ability to excrete the acid, resulting in the accumulation of metabolic acids in the blood. So the complications of CKD, okay, so there is disease progression which leads to the CKD, there is hyperuremia, and there is CDP accumulation. And the complication, there is a constellation of complication, which is insulin resistance, vascular damages, immune response disorders, renal fibrosis, hemostatic dysfunctions, and EPO resistance, and whatnot. So these are the complications of chronic kidney disease. So abnormality of the kidney structure or function that is present for 3 or more months is called as chronic kidney disease. So there is damage to the kidney tubules, atrophy, and kidney interstitial tissue which undergo fibrosis. The kidney damage leads to the decreased erythropoietin production. There is decreased stimulation of bone marrow, and there is decreased RBC production, which leads to the anemia. Also, due to the buildup of the toxic substances like urea, there is toxic damage, which decreases the red blood cell survival, and again it will lead to anemia. And there is also uremic syndrome. The decreased conversion of calcidiol to calcitriol in by the kidney leads to the decreased calcitriol levels in the blood, which causes decreased calcium absorption from the small intestine, and it will ultimately lead to the hypercalcemia. And whenever there is decreased calcium in the blood, it will increase the PTH secretion and will cause secondary hyperparathyroidism. And again, due to the decreased GFR, there is decreased renal excretion of phosphate. There is again increased phosphate in the blood, which leads to hyperphosphatemia. This hyperphosphatemia will increase the serum phosphate binding with ionized calcium, and ultimately decrease the blood calcium level into hypocalcemia, and again secondary hyperparathyroidism. The decreased GFR also lead to the decreased renal excretion of ammonium, and which can lead to metabolic acidosis, or you can say increased anion gap metabolic acidosis. The decreased renal excretion of salt and water will lead to increase in the extracellular fluid and systemic volume overload, which can lead to hypertension and pitting edema. Also, the decreased excretion of potassium will lead to hyperkalemia. Also, the vascular calcification can lead to atherosclerotic diseases, and there can be dyslipidemia or triglyceride, which can be also presented in case of chronic kidney diseases. So if there is kidney damage with normal or increased GFR, okay, which is more than 90, we need to diagnose and treat the chronic kidney disease, and we need to slow down the progression of chronic kidney disease. If there is mildly decreased if there is only mildly decreased GFR, we need to estimate the progression of the disease, how fast the disease is progressing, and we need to slow down the progression again. If there is mild to moderate decrease in the GFR, the complications start coming up, and we need to evaluate and treat the complication. And whenever there is severely decreased GFR 15 to 29, we need to prepare for the renal replacement therapy. We need to start making of the fistulae and all, AV fistulae and all for the hemodialysis. And whenever there is decreased 15 GFR, then we need to go for the renal replacement therapy if uremia is present, or you need to go for the hemodialysis in the patient. So what are the complications of chronic kidney disease? Okay, so anemia. So erythropoietin injections of hemoglobin if the hemoglobin is less than 10 gram per deciliter. So we need to have a target hemoglobin concentration of more than 13. For in case of renal osteodystrophy, the phosphate control is typically initiated with a calcium-based phosphate binder. So these all are the complications under management. So hyperkalemia is treated by dietary restrictions and diuretics. Acidosis is treated by sodium bicarbonate supplementation. Pericarditis, we need to initiate the dialysis or increase the dialysis dose. We cannot go for NSAID in this patient. The cardiovascular disease uh, can be presented there, and we need to manage accordingly. There can be vascular catheter related infections because we are doing dialysis with the patient. So the catheter related infection, the most common organism is Staph aureus, and this question is very commonly asked in the examination. The peritoneal catheter associated peritonitis, the most common organism is again Staph aureus or Staph epidermidis. Thank you for watching. Keep studying hard.